and it collects in the bladder. Okay, that's the indirect method. If you do the direct method, you basically put a urinary catheter in there and you fill up the bladder. Okay, and what's important about that, especially with children, is that you need to know how much you can safely administer. There's a real good section in our math book that tells you how to calculate it. You get the age of the patient. You know, normally it's for kids under the age of 9. So between the ages of like 1 to 9, you take their age, you add +2 to it, and then you multiply that times 30 ml. That's the quick way of doing it.
That's
So,
the maximum water.
yeah, if I was 4 years old, okay, so 4 + 2 = 6, right? And then I multiply that times 30 ml. And that would tell me that the bladder capacity is probably about 180 ml. Okay, and that's these calculations are, you know, I don't know how many people actually do them. Most of the time they're just looking for, you know, things like reflux and stuff like that. So they really don't. Normally they'll try to see at what amount of fluid in the bladder it takes to have a reflux. So you have to be very, you know, you have to monitor how much you're putting in, so that you know at what point the patient has a reflux. Let me just see what page that's on here. Page 228 of your math book. Obviously now you know to look at your math book because you'll probably get calculations from it.
When you do that procedure, would you inject the technetium into the saline bag?
Yeah.
You would, okay.
What patient? Would that be too soon?
Wouldn't that just be like emitting radiation when you're standing there? Like, wouldn't it be better to inject it right at the tube right before it enters?
Well, yeah, I wouldn't. I would. You know, the thing is, you kind of want it uniformly dispersed. That's one of the problems. But this is on page 228. So you may see this thing here. This is so for children under the age of 9. This is the equation that you would be using. That way, you don't put 1,000 ml in some poor kid's bladder. You know, they'd be like a fountain putting out their ears and their nose and stuff like that. The other thing over here is quantification. And again, if you work in a really sophisticated nuclear medicine department, they do things like this. You know, most nuclear medicine departments, they're not really concerned about this type of stuff, which is unfortunate because if you have the ability to do stuff like that, it's always good. But if you're doing a cystogram, this is on page 229, okay, you collect all of the urine. So basically, after the patient, you know, you've injected them, you've done your imaging, you have them urinate, you collect it, you count it, you take region of interest, you know, over the bladder before they void, you take a region of interest after they void, so you have those counts there, and then, like, let's say that they had 180 ml, so you collected 180 ml. You multiply that times the post-void counts, and then divide it by the pre-void minus the post-void counts from your region of interest. I don't think, have any of you guys done that? No? Okay. It's kind of a surprise the first time that somebody asks you to do this. That's why I strongly suggest that, you know, after you graduate and you get your boards and everything, always take your books with you. It's a good idea to have them someplace where you know, can review things like this when it comes up. Okay, so this is your residual volume, because remember, one of the problems that we have, especially with urinary tract infections, is the person doesn't get rid of all the urine. So any type of obstructive disease like a prostate enlargement or cervical cancer, things like that would prevent urine from leaving the bladder. And just, you know, in general, children often have a problem completely eliminating all of the urine. Okay. So now you have a beautiful environment for bacteria to grow. Okay. And you've probably realized that most of the studies that we do, especially in renal studies on children, are this type of a procedure. You calculating cystourethograms. I know in radiology we do a lot of them, but this is give you an idea. This is just one application of it here. Once you have the residual volume, then you can calculate the total volume of the bladder. Notice that the total volume is whatever the patient voided plus whatever you calculated up here. Does that make sense? Okay. If we're calculating reflux, we have the same formula that we used for doing the gastric reflux. So basically, the reflux volume, so reflux region of interest counts, and then blah, 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 blah. So you can actually calculate how much urine is actually going up. One of the major types of infections that we deal with are what they call ascending infections. So what happens is you have especially young children who, when they poop, they defecate, they don't change their diapers immediately. Either mom and dad don't do it, or the kids outside playing. I remember when I was a kid, I mean, my friends and I would stay out there. We'd have, probably 3 days of poop in our diapers. So, it was more fun than outside playing than it was, and the smell was something you didn't care about. But the bottom line is that the bacteria, and what's one of the more common bacteria in your colon? Okay, E. coli. E. coli is probably the biggest bacteria that causes infection to the urinary system. It occurs in the hospital. You have an older patient that has a catheter in them, and they poop, and the nurses don't just rush right in there and clean them up afterwards. The catheter is like a freeway for the bacteria to enter the bladder. E. coli, it's very happy when it's in your intestines. When it gets into your urinary system, it's potentially fatal. In fact, in most cases, it is. It gets into your blood, and you get septicemia, and winds up killing you. It's also a very difficult bacteria to kill. It forms a spore whenever it's in a hostile environment. So it'll form a spore, and you can't kill it with your normal disinfectants or things like that.
It lives long.
It lives a long time. There's also what they call VRE. Have you heard of VRE? Yeah, vancomycin resistant enterococcus. That killed my mother-in-law. Somebody contaminated themselves with it. They went into my mother-in-law's room. When they told us that she had it, they said she has anywhere from 2 weeks to 6 weeks to live, and she made it about 3 weeks. Yeah, MRSA is another good one, but VRE is a little bit more, But like I said, people who are in the hospital and they have catheters in them, and people don't get their stuff changed and cleaned very quickly, you have a problem. Okay, so going back to our so we have 2 kidneys. The level is important. Remember that sometimes people have kidneys where when they stand up, the kidneys will fall down. There's nothing supporting them. Normally you have like 2 suspensory ligaments that are holding the kidneys up. What's the medical term for a drooping kidney?
Start with an N.
Yeah, nephrotosis.
There you go.
Okay, and that's why it's important. If the patient has that type of a problem, then you definitely need to not only do the supine films, but you need to have them stand up and see what happens. Because normally if they stand up and the kidney falls down here, that means that you get kinks and blockages in the ureter. Okay?
We had one yesterday,
Uh-huh.
and we were doing a bone scan on her, and we couldn't figure out what this, it looked like a mass, because it was like right above the bladder. Well, she had a cyst so big that her kidney had come down underneath the cyst.
Oh,
And it
wow.
was probably 5 inches out of place.
Oh,
It was
wow.
pretty crazy. And her kidney was all just like squished, so it was all like the shape of it was like really long and yeah, it was all messed up.
Oh, wow. Yeah, well, you know, this is why when you guys are doing studies, look at the whole picture. You know, like if you're doing a bone scan, remember that, you know, our bone scanning agents not only go to the bone, but they also go to soft tissue tumors. And sometimes on a bone scan, you'll see a patient that has an obstructed kidney. You know, if you see that the kidney is not filtering your bone scanning agent out, that's significant. That's pathology. So always look at the whole picture whenever you're doing these scans, because a lot of times you'll pick up something that maybe somebody wasn't aware of. I know that I've done several bone scans and we've had a stone blocking one of the ureters. So, okay, so we've got 2 ureters, 2 kidneys, we've got the urethra. And again, the urethra, it's, you know, obviously longer in a male than it is in a female. And a lot of times the length of this also determines your susceptibility to infection. So that's why I said if you have fecal contamination, it's a lot easier for the E. coli to travel a couple of inches rather than, you know, 5 or 6 inches. So, but this is often the route that the bacteria take to get into your system. Okay. So, also, what are these things up here, guys?
Adrenal gland.
Okay, adrenal glands. Okay, just make sure that. Okay. Let me just go ahead and put all of the things up here. Okay. We know that it gets rid of waste products. We know that materials that your body needs, it reabsorbs those and puts them back into the bloodstream. You know, so things like glucose. There's a molecular size. They have a unit called the Dalton that they use to measure molecular things. And typically anything 70,000 Daltons or less is excreted out into the glomerulus. Okay? Then through a process of diffusion or osmosis, in the proximal tubule it gets reabsorbed. And when the concentration in the tubule and the blood is about equal, which usually occurs in the distal collecting system, then the kidney has to utilize active transport to get those other items back into the bloodstream. So the kidney uses 2 methods of reabsorbing this stuff in the tubules. Okay? And again, you know, minerals that you need, you know, those are, you know, your kidneys can often tell that you need more calcium or more sodium or whatever, so it can help regulate that. Blood volume and blood pressure. One of the interesting tests that we do on patients when they come into the hospital, especially when they have renal problems, is intake and output. Have you guys ever seen that on your patients? INO orders? So that means if they urinate or anything, anything you give them down in the nuclear medicine department, or anytime they have a pee or poop or anything, you have to collect that and send it back up with them. You wrap it up, send it FedEx.
In a paint bucket?
Well, here's the thing. Okay, when they say that it regulates blood volume and blood pressure, if I drink 100 ml of water, that means at some point I'm going to urinate 100 ml of urine. Okay? So that's why when patients are being observed for their kidney function, they know approximately how much water there is in fruit that they eat or sandwiches that they ingest. So all that stuff is known to the dietary department. And what we want to make sure of is that they're not retaining water. Okay, one of the big things, people that have congestive heart failure, people that have renal problems, they start getting excessive fluid in their legs, edema. And I've seen it where the edema actually can, you know, the whole legs are enlarged, and I mean right up to the mid-torso. People like that, they normally have to weigh themselves every morning, or several times a day. I got stuck. Because if they start gaining weight, that means that they're retaining fluid, and that means that the heart has to pump harder to get that fluid circulated. And if you're borderline congestive heart failure, or if you do have heart failure, you're probably going to, you know, complete heart failure. So you probably have a big problem with it. The osmolarity of body fluids. Now remember, what is osmolarity? You're going to hear that again, especially when you guys talk about iodinated contrast
Is
media.
it the water, the
It's like
thickness of
the
the
ratio.
yeah.
The
of
ratio.
The solids, like dissolved solids inside fluid.
Okay, it's the number of particles in a fluid. I'll give anybody who knows what the number of particles in your blood is. Yeah. Ooh, no. Anybody else?
Specific gravity or osmolarity?
Yeah, the osmolarity of blood. We know that specific gravity is, you know, comparison of something to water.
1 to 200 milliosmoles
Oh,
in the
no,
serum.
you're close.
That's a full-
How about up north? Ashley, same? Okay, you have about 300 milliosmoles in your blood. And what that means is when you put in drugs or, you know, in the case of contrast media, if you put in something that has a higher osmolarity, it sucks the fluid out of your red blood cells or out of any of the cells that are in the surrounding area and causes them to shrink. On the other hand, if you inject a lot of water, you know, that has low osmolarity, and that causes the cells to take in the water and swell up. You guys remember that from your physiology?
Hyper and hypertonicity.
Yeah, hypertonic and hypotonic solutions. Okay, and this is a big problem for, I mean, when you guys take your class on intravenous contrast media, you know, when you're doing a PET CT class or something, it's a big issue. Because the two major effects that we see from contrast media, one of them is affecting the kidneys. You know, when they inject the contrast to do a CT scan or a PET CT scan, the injection of contrast causes a lot of fluid to be sucked into your bloodstream. And the kidneys don't like that. So when you get a lot of fluid that comes in and then all of a sudden it rapidly leaves, that puts the kidneys into what we call acute tubular necrosis. Okay, anytime you disrupt the blood flow to the kidney or you disrupt the blood or the volume of fluid that they have to filter, they don't like it. So they temporarily or even permanently can shut down. Does that make sense?
When a high osmolar compound is injected.
Yeah.
Tubular. Acute tubular necrosis.
You know, if, like I said, have any of you guys seen a patient that was injected with iodinated contrast? I mean, you will eventually. You'll probably be doing studies on it. But the patient will complain that they get hot. They feel warm all over. And that's because all that fluid is being sucked into their circulatory system. If they have a bad heart, it can actually put them into heart failure. If the kidneys are sort of borderline functioning, you'll probably put them into renal failure. Okay. But the osmolarity, like I say, your blood has about 300 particles or 300 milliosmoles per deciliter. The contrast media, it's usually higher than that. So they have what they call high osmolarity, which has like up to 1,500 milliosmoles. And then they have what they call low osmolarity, which is about 400 or 500. And then they have what they call isoosmolar, which is the same osmolarity as the blood.
So a high is 1,500.
Yeah, it can be up as high as 1,500. But here's the, okay, and again, the problem with that, the other problem that you have with these contrast agents is allergic reactions and anaphylaxis. Remember, anaphylaxis is a type of shock that a person can go into from allergic reactions. And
What's the normal level?
300.
it's about 300, the blood is about 300 milliosmoles.
How is 400 and 500 mil? And 300 is?
Well, 300 is what the contrast is compared to the number of particles that are in your blood. So if your blood is 300, but I'm injecting something that has 400 or 500, that's slightly higher. So they call that a low osmolarity contrast agent. Some of them have a lot more iodine and particles in it. You know, basically when you inject this stuff into a patient, the contrast agent breaks up. Some of them do, some of them don't. Okay. But the bottom line is that it creates a lot of problems for the patient, and especially if they have renal problems. So a lot of the patients that we do renal scans on are ones that they can't use iodinated contrast. Either they've had a previous contrast reaction, or the kidneys are not functioning, and so we get it. Okay. This one here secretes renin, activates angiotensin, aldosterone. This is an interesting one here. Your kidneys have two mechanisms for regulating blood pressure. Is blood pressure important to the kidneys?
Very.
Yeah, very. You have to have a certain amount of what they call hydrostatic pressure in the glomerulus in order for the filtrates to be excreted. Okay? It's all based on hydrostatic pressure. And that's regulated by two mechanisms. One mechanism is where you have pressure receptors that actually measure the blood pressure coming into the kidney through the afferent arteriole. Okay, they're called baroreceptors. Baro meaning pressure. And then the other mechanism is where after the blood vessel has gone through and recollected all of the solutes and electrolytes and everything back into the bloodstream, it passes through an apparatus called the juxtalar glomerular apparatus. You guys remember that from your...
Yeah.
Okay. The juxtalar glomerular apparatus has cells in there called the macula densa. And those measure sodium levels. When the sodium levels are high, it tells the body that the kidneys are not, there's not enough pressure to filter out the sodium. So it stimulates the macula densa to release renin. Okay? We're going to talk about that. The reason we bring this up is because we do a test for this. Mr. Singh, what test do we do to evaluate renin secretion in the kidneys? Ashley?
In Nuc Med or in general?
In Nuc Med.
No, arenogram.
Huh?
Arenogram? I don't know.
Well, it's part of arenogram.
Renal hypertension and capital.
Yeah, it's what they call, it's the captopril. It's a arenogram with captopril. Yeah, it's for renal artery stenosis. Because, well, we're going to look at the blood supply to the kidney here in just a minute. But if you have a blockage of the renal artery, that's going to lower blood pressure to the kidney. That means with less pressure in the glomerulus, it's not going to filter as efficiently. So basically, you've taken that mechanism out of play. You know, normally these baroreceptors that are monitoring blood pressure coming in from the renal artery, they allow the blood vessel to expand or constrict. You know, if I'm exercising and my blood pressure goes up, I don't want my kidneys to be filtering, you know, because of the excess blood pressure. Okay? So your baroreceptors will tell the renal artery to constrict and lower the blood pressure. Okay? When I'm resting, the baroreceptor allows the renal artery to open so that more blood's coming in. But if I have a plaque in there, now remember the three major arteries that are affected by plaque are your carotid arteries for strokes, your coronary arteries for heart attack, and the renal arteries. A lot of times people have high blood pressure, we call it idiopathic hypertension. What does idiopathic mean?
Unknown cause.
Yeah, we don't know why. You know, it's.
Idiot.
We had a doctor over at St. Bernardine's here in San Bernardino, and a patient would come in, you know, say, "Doctor, you know, I'm coughing all the time. I'm, you know, feel horrible, and you know, blah blah blah." The chest X-ray would be perfectly normal, but the radiologist would say the patient has nonspecific pneumonitis, which means he doesn't know why this person is coughing, but you know. When you tell somebody, yeah, you know, you got nonspecific pneumonitis, they, oh my God, am I going to live? You know, basically it's just like a catch-all. We don't know what it is. So idiopathic hypertension, what it turned out to be was renal artery stenosis. And so one of the tests that we do to evaluate it is captopril. We'll talk about how that works here in just a second. But this mechanism here We had talked about this in the endocrine system. So when the sodium levels are high, as the blood is leaving back out through this, this tissue called the macula densa, it will secrete renin. Renin then activates angiotensin. So this turns it to angiotensin 1. Angiotensin 1 goes to the lungs, where it's turned into angiotensin 2. When it comes back to the kidneys, it causes constriction of the efferent arteriole. This is the arteriole that's taking the blood back into the circulation. When I constrict that blood vessel, that raises pressure inside the glomerulus, and I get better filtration, hopefully.
Regarding that, doesn't renin convert angiotensin again to angiotensin 1?
Yeah. Yeah. Normally I just call it angiotensin. So, but it does angiotensin to angiotensin 1. Goes to the lungs where it's modified. It's a very powerful vasoconstrictor. Now, the problem is if you have the macula densa producing a lot of renin, okay, now it's not only going to affect the efferent arteriole, but it's going to affect the systemic blood vessels. Okay? So it's producing too much renin. And then we have aldosterone. What does aldosterone regulate?
Sodium, that concentration of sodium in water.
Yeah, sodium, water, and potassium. Okay? Yeah, it gets rid of potassium, increases sodium. And remember, we need sodium and potassium because of the muscle contraction and things like that. Okay? And that in turn also helps regulate your blood pressure. So, is everyone okay on that, sort of? Until I give you a test on it? Okay. This is another thing that's interesting here, erythropoietin. We talked a little bit about that in the endocrine system. What does erythropoietin do?
Hormone that stimulates RBC.
Right, it stimulates your bone marrow to produce red blood cells. The kidneys are one of the very important organs that are sensitive to oxygen deprivation. So if the kidneys are not getting enough oxygen, they are going to start secreting erythropoietin. And that's going to cause the bone marrow to start producing more red blood cells. Some of the things that happen, well, for example, if you move from here to Colorado, okay, Colorado is a higher elevation, it has less oxygen. And so what would happen then if your kidneys are sensing less oxygen?
Red blood cell stimulation.
Yeah, over a period of time, either your kidneys are going to start secreting erythropoietin, you're going to get more red blood cells. I don't know if you've ever wondered why the Olympic athletes train at Colorado.
Like
Yeah,
blood doping.
it's like blood doping, exactly. You know, a lot of athletes, they'll take out several pints of blood before an athletic event, and then just maybe a day or two before the athletic event, they'll re-inject themselves with the blood. I don't think so. But I mean, it's hard to detect, though. You know, when people,
Why we do
It's
that?
not really illegal if you train at different altitudes.
no, yeah, if you train in Colorado, that's not a problem. But see, that's one of the reasons why they do it, is because you're artificially creating more red blood cells.
Polycythemia, something
Yeah.
like that.
They actually call it secondary polycythemia. Okay, sometimes you have bone marrow that is overactive in producing red blood cells, and we normally have to kill it. If you produce too many red blood cells, your blood gets very thick and it starts obstructing flow into organs, and you start getting,
Smokers too, right?
yeah.
Get the same.
But
If
this
you
is,
donate too much blood, I heard it makes you polycythemia.
if you lose blood, anything that causes the oxygen levels in your blood to go down is going to cause the release of erythropoietin. So if you donate a lot of blood, if you live at a high altitude. Now, one of the things that happens to patients that have renal failure, okay, let's say your kidneys die for some reason, okay, they become anemic because they're no longer producing erythropoietin. Erythropoietin has been isolated, and they give it to cancer patients. You know that when patients are getting therapy, you know, either chemotherapy or radiation therapy, their bone marrow gets really wiped out, their blood cell counts go way down. So they have this stuff now, it's called Procrit. And what they do is they inject erythropoietin into cancer patients, and that causes what remaining bone marrow they have left to produce more red blood cells. So it helps bring their blood cell counts up so that they can either continue treatment or they don't feel so wiped out. Yeah, I don't know if you guys have ever seen the commercials for it. I haven't seen them on recently, but they used to have these commercials where you have some poor emaciated guy who, I have cancer, but since they've been giving me Procrit, I can now, go out and do everything, whatever. So that's how they're marketing this stuff. But yeah, they're using erythropoietin on cancer patients. It does regulate your carbon dioxide in the blood too, to control the pH of the blood. Okay. And then lastly, we have detoxification. So free radicals. What the heck are free radicals? Huh?
It's, they like don't have one electron or something, not that, something along the lines where they're very reactive species.
Actually, this is all the stuff that causes radiation damage to you. Did you know that? When radiation hits water in your body and ionizes it. Free radical is when you normally break a covalent bond. So when you take an electron off of water,
What's the notation if it's like H and a dot? It's just
you
H
have
and a dot.
hydroxyl and hydrogen radicals. I only bring that up because of, well, I want to make sure that you guys have all the trivial information that you need, We haven't talked about radiation protection, but normally, just real quickly, I want to just... Free radicals are something we're going to be talking about a little bit later. Okay, if you have water and you expose it to radiation and you remove an electron, okay, then what happens is you're going to create, well, first of all, let's take a look at how a water molecule is set up here. Okay, we have oxygen. It actually looks like Mickey Mouse. For some reason, the hydrogen is up at the top of the molecule. And because hydrogen only has one electron, it has a covalent bond. Okay. So whenever you remove an electron from a water molecule, you make it very unstable. And this is why you have all of these vitamins and people now that are marketing that removes free radicals. Because this is what causes cancer. This is what damages the DNA. 95% of the damage that we see from radiation is caused by this. It's called the poison water theory. Okay. So what will happen is whenever you break a covalent bond, this is what they call a hydroxyl radical. And if I remove the electron from water, that's what happens, and then you get a hydrogen ion. So you get a hydrogen with a plus charge. This electron can travel over to another water molecule and destabilize it. So in other words, here's H2O over here, and this electron will travel over here, destabilize this water molecule, and then what we get is a hydrogen radical and a hydroxyl ion. Okay. So all the effects of radiation that we're trying to protect you and the patients from is this process here. This is 95% of the damage that we see from radiation. The other 5% is when the radiation hits your DNA and causes mutations and cancer and stuff like that. So, but in fact, a friend of mine gave me all these tablets for radiation exposure, and they're basically a lot of antioxidants. Okay, so if you want to protect yourself, you eat a lot of vitamin C and stuff like that, and that'll help protect you. The bad news is that a lot of times cancer patients are taking a lot of vitamins and they're actually defeating the purpose of the radiation therapy.
Catch 22.
Yeah, so they don't want you to be taking vitamins and stuff like that when you're being treated for cancer. Okay, but again, the other problem that you have is you can actually poison the kidneys. So that's one of the bad things from this. Okay. The other thing down here, gluconeogenesis. Remember that the kidneys are designed to keep all of the sugar that your body produces. Okay. Glucose is the major energy component for your cells. And so the kidneys are designed to reabsorb sugar. Now, unfortunately, when you have diabetes mellitus, you have so much sugar, it actually spills over into the urine. When I was a student here at Loma Linda, they still used to do what they call a taste testing. Greg's laughing here, but yeah, if you wanted to go into microbiology and work in the lab, one of the things you had to do was take patients' urine and put it on your tongue and taste if it was sweet or not. Yeah, I completely ruled that out immediately. Said, man, you know, you're gonna die. You got diabetes, you're just gonna die. Yeah, just wait till your feet fall off and you know.
Taste test.
Yeah, it's a taste test. But again, you know, because the kidneys are doing that, keep in mind. So these are the nitrogenous wastes that were, and these are the three major types of things that we measure for nitrogenous wastes in the kidneys. Most of them, the urea and creatinine, both of these come from the breakdown of amino acids and proteins. Okay. So notice that urea, the ammonia, NH2 is ammonia, goes to the liver converts it to urea, and then it's excreted. Uric acid, we don't normally see that except in cases of what they call purine metabolism disorders. So this is gout. Okay, and this is why, and then the other thing, creatinine down here, again, this is in the anaerobic, or the non-anaerobic creation of energy ADP to ATP.
So, aerobic?
Yeah, or actually it's the anaerobic. We have one that requires oxygen, this is the one that doesn't require oxygen.
Oh, anaerobic.
Yeah, so basically like lactic acid being converted in the Krebs cycle. I wish I could remember the Krebs cycle, but right now, you know, it's too early in the morning.
As pyruvate.
Yeah, you take the pyruvic acid and lactic acid and make them back into creatine. This is what they sell at, what is that, GNC? That,
Monohydrate.
yeah, this is actually broken down waste products that people are taking and eating and putting back in their body to get more energy. But that's a source of energy, though. It works.
The spurts, short spurts, right? That's the first
Yeah, and I know-
source.
I think a lot of the baseball players didn't. I think that one guy that hit 80 home runs in a year. Both of them were doing that.
McGuire
Yeah,
or Sammy Sosa?
I think both of them were doing something. But I think Mark McGuire, they went to his locker and they found boxes of creatine in there and stuff like that. But the uric acid, again, one of the things that we want to be paying attention to is when, especially people have stones. Okay, if they have kidney stones are usually either calcium, okay, or uric acid, or oxalic acid. If it's a calcium stone, what would that trigger as far as you guys? What kind of pathological condition would you be thinking about? Okay, would you say, Ashley?
Parathyroid.
Okay. Yeah, and that's absolutely true. That's one of the things that you would be doing a parathyroid scan for, is a patient that has calcium stones. If they have gout, okay, gout is a purine metabolism, they would have excessive levels of uric acid. Remember that uric acid crystals normally wind up destroying joints and things like that. Okay. And then, okay, the other thing that we look for is this term azotemia. Okay, when the kidneys are not filtering at all, these nitrogenous wastes build up in there, and we have this term azotemia. On your board exams, you will have some medical terminology. Okay, so they may give you a question that says, okay, azotemia means blah blah blah, or a person that had excessive amounts of nitrogenous waste in their blood would have which condition? Okay, that type of stuff. Okay. Then another thing here, uremia. Okay. If you have too much waste, built up in your blood, and the kidneys aren't filtering it, this uremic toxic effect that people get like a copper color to their skin gets real itchy, because if the kidneys are not filtering it out, then normally it's filtered out through the skin. And I'm going to send this to you guys, so don't worry about it.
Is azotemia like if your liver can't convert the ammonia into urea?
Yeah.
So that's another way of getting it?
Yeah, well actually what will happen is even if the liver can't convert it, because what's supposed to happen is the liver converts it to urea and then it's excreted. So unfortunately the liver is still processing this stuff, but there's no mechanism for it to excrete. So it starts going out through the skin. And then, like I said, they get this real itchy, copper-colored, dry skin. It's not a good situation, to say the least. Okay. Okay. Now, waste products. How are they removed? We've already talked about one mechanism here. We talked about carbon dioxide from the skin, from the lungs. We said that the skin, which we haven't talked about. A lot of this stuff goes out when you perspire. Your digestive system, we've already talked a little bit about this, water, salts, bile, pigments, cholesterol. And then the urinary system basically handles most of your metabolic waste. I mean, it is the actual mechanism that's excreted out of your body. Okay? So that's why we were talking about, when you're getting a patient history, we need to look at how the kidneys are functioning, but you also need to ask the person, what type of work do they do, what type of recreational drugs are they using, things like that. I hate to say it, a lot of people put themselves in a mess when they do this. And then, like I said, hormones, after the liver detoxifies your hormones, and as you remember from last week when you had the thyroid test, the liver and the kidneys get rid of hormones. Okay. Yeah, this is the important stuff here.